Hey everybody, welcome to Screencast 11. I'm your instructor, Dr. Toby Brooks. Today's lesson is going to focus on musculoskeletal anatomy in the trunk and spine. Now this is certainly an area of the body that's kind of surrounded with confusion. There's a lot of highly specific anatomy that maybe you're not as familiar with. These aren't bodybuilder muscles. These aren't areas of the spine where we tend to see a lot of traumatic fractures. Certainly injury can and does occur here. However, because it is centrally located in the anatomy, lots of times we don't know as much about it. So we're going to take some time today to talk about the uniqueness of the trunk and spine. We're going to look at the skeletal anatomy and its features. We're going to take some time to look at the muscular anatomy and its features, and then the movements that are associated with the corresponding levels of the trunk and spine. So first things first, the skeletal components of the spine are highly complex. In the arm, we talked about the humerus, the radius, and the ulna, and that was it. Okay. In the spine, we know there are vertebrae. However, the aspects of the vertebrae are highly specific. They articulate one with another and with the ribs, and there's just a lot of kind of confusion associated with the fact that the structure is so highly specific. Along those same lines, the muscles that move the spine are not necessarily huge prime movers that have long lever arms and produce lots of powerful force, but rather usually they function in groups, and a little bit of motion at an individual segment compounded together produces the kind of movement that we're after. So the muscular complexity is probably significantly higher than what we've seen in the appendicular skeleton. Now those muscular attachments, like in the quadriceps, we don't have a corresponding big bony prominence in the spine like we would have for the tibial tubercle, let's say. So those attachment points are a little more subtle. We're not going to see large prominences where these muscular attachments occur. Usually just broader, sheet-like, and like we said, those muscles tend to function collectively rather than individually. Now, if we just take a second to look at the skeletal anatomy, we can kind of count those structures up and divide them up based on what we see as far as their structure. Now, lots of times in anatomical kinese, you think, I've got to memorize all this stuff. But it really is logical. As we've said before, muscles are named for position, they're named for function. The skeletal structure, the architecture of the spine is functionally grouped. So if we count up the individual segments and then we just kind of look at, okay, this curve kind of looks like this curve and this one's different, we can kind of see right off the bat that not every segment looks like the one below it. Okay, these up top are shaped completely differently. Their bodies are thinner, whereas down low the bodies are thick, they're substantial, they're designed to bear weight, and the movements that are possible at those segments varies based on the shape of that given vertebrae. Okay, so if you just take a look at this for a second and kind of count up how many bones are involved in the vertebral column, kind of how you might group them functionally, and then how many are in each group, you start to see right away that there's really kind of three primary groups here, and I can count. Okay, in this top group, this one's totally different, and we'll talk about it. 1, 2, 3, 4, 5, 6. These top 7 all look different from this curvature group, and there's 12 there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 that are shaped and have this anterior concavity. Okay, and then down low we've got these 5 big vertebrae, 1, 2, 3, 4, 5, that have a different shape still. Okay, so in looking at that shape, we can see that the cervical vertebrae allow a greater range of motion. And if you've ever woken up after sleeping oddly and you got kind of a crick in your neck or pain in your neck and you're kind of turning and looking at people by turning your whole body, you understand pretty quickly that that cervical range of motion is really, really important for normal function, let alone athletic participation. Okay, that's because of the orientation of what are referred to as the facet joints. So the facet joints are the joints left and right, lateral, of adjacent vertebrae. So a superior facet will articulate with an inferior facet of the bone above it. So in the cervical area, these facets are oriented backward, upward, and medially. So it's not tabletop, it's not classic transverse plane, it's not classic frontal plane, it's kind of a split between the two. So that's going to accommodate multiplanar motion relatively easily. Now the thoracic spine, on the other hand, have this kind of bull alignment, so backwards, upwards, and lateral. So think a little bit more kind of wall or frontal plane. So this is going to allow lateral flexion, and then it's also going to allow frontal flexion and extension. And then our lumbar vertebrae are located, or are oriented rather, a little bit more backward and upward again. So we're thinking more sagittal plane. So this is going to allow flexion and extension, but not a lot of rotation. Okay? And a lot of our back pain, it's because we're moving segments of the spine in ways that they weren't really designed to move. So we want lumbar stability, for instance, core strength. So if we look at the specific parts of the vertebrae, the big bony prominence out back is the spinous process. So if you palpate the back of your neck, that first bony bump you feel, that's the big spinous process of C7. So if you go back and look, you can see the very first one you see that's really prominent, that's C7. So that spinous process is there. The body, on the other hand, is kind of the anterior aspect of the vertebrae. And as we go lower and lower, as we descend down the spinal column, the bodies get thicker because each one is bearing a greater percentage of the total body weight. Okay. Now these transverse processes, in the case of the thoracic spine, articulate with the ribs. And then we've got this vertebral foramen in the center where either the spinal cord or the cauda equina passes through, depending on what level of the spinal column we are on. Now between adjacent vertebrae, skeletal structures, we've got a fibrocartilage disc. Now fibrocartilage, you'll remember from our discussion of knee anatomy, it's not highly vascularized. It provides cushioning and shock absorption, and any one disc doesn't provide a tremendous amount of cushioning or shock absorption. But if you consider each level of the spine has a disc between it, you start to see that collectively we have a fair amount of shock absorption in the spine from top to bottom. Okay, so these discs have a tough fibrous annulus. That annular goes around, kind of encases that disc, and then more of a gelatinous nucleus pulposus, which is even better suited for shock absorption. Okay. Now, if you just consider the ways that the cervical spine moves, think for a second of the different ways that you can move your head and neck. Okay, I'll give you a second. Don't look at your notes. Don't look at your textbook. See if you can come up with answers on your own. Okay. So if we think about how that cervical spine moves, we know we can agree, not in agreement. Okay, so flexion and extension are going to occur in the in the sagittal plane. Okay, just as we talked about flexion and extension in the upper extremity or in the lower extremity, occurs primarily in the sagittal plane. Now, in the cervical spine, we can also rotate left and rotate right. So that's a transverse plane motion. Okay, we can also side bend left and right lateral flexion. That's more of a frontal plane movement. So we've got triplanar movement possible due to that facet joint orientation in the cervical spine. Lots of range of motion here. A minor injury can really compromise range. Anything from a minor muscle strain to a muscular spasm can negatively impact motion here. Okay. In the thoracic and lumbar spine, we don't have as much movement. So remember in the shoulder we talked about mobility versus stability. And the more mobile a segment is in the cervical spine, for instance, the less stable it is. Well, in the thoracic spine, we kind of have a split there where we're more stable and we're less mobile. And in the lumbar spine, even more stable and even less mobile. Okay, so in these segments, we've got flexion and extension again. We still have left and right rotation and left and right lateral flexion, but because of the orientation of those facet joints in the thoracic spine, more kind of frontal plane, we can lateral flex a little easier. Whereas in the lumbar spine, we've got more of a sagittal plane orientation and we're better suited for flexion and extension. So if I'm kicking a soccer ball or if I'm doing a hamstring stretch, for instance, lots of people have really poor hamstring extensibility, but they can still touch their toes because they've got enough extensibility in the lumbar spine that their upper extremity can reach further than it probably should. Okay, they're not getting that toe touch from hip flexion as much as lumbar spine flexion. Okay, so those movements still occur there, but they occur to a differing degree than they would in the cervical spine, for instance. All right, so we're going to take a look at just some of the muscular anatomy of the spine. The SCM, or sternocleidomastoid, the erector spinae, the rectus abdominis, the obliques, we'll look at them individually, and then the QL, the quadratus lumborum, and then the transversus. Okay, these are all critical spinal prime movers and stabilizers. Okay, so first things first, if you take your finger and put it right at the base of your neck and side bend to the right, you'll feel your left SCM kind of pop out at you. Okay, and by the same token, if you turn left, you'll feel the right. Okay, so that sternocleidomastoid, named for its attachment points. Okay, so it attaches to the sternum, and then it also attaches to the mastoid process. So sternum and clavicle, clavicle. Okay, so it's going to originate medially and anteriorly, and traverse superiorly to the mastoid process of the skull. And if we contract both sternocleidomastoids together, it's going to result in flexion. However, as we already felt, if we do one side or the other, unilateral activation is going to cause rotation to the opposite, to the contralateral side. So this muscle is innervated by the spinal accessory nerve. Okay, so if you're really stressed or if you're really strained, lots of times you can kind of see that SCM kind of pop out. Now the erector spinae, it's a big, broad collection of muscles in the posterior spine. It's actually composed of 9 separate muscles. Your textbook will actually kind of break those out into individual components. For the purposes of this course, I won't have you do that. If you're planning to go to PT school or athletic training, OT, you will eventually have to learn those, and they're important. But in terms of athletic performance, the erector spinae really functions collectively, so it's not like a loss of function in one segment of my rotatoris brevis is going to significantly decrease my ability to punt a football. It's just not going to happen. We almost treat it like a singular muscle, even though it's not. Okay, so it's going to originate on the posterior spine and the ribs, and it's going to insert on the posterior spine and ribs, usually a segment or two above or below. Okay, so as the name would tell us, it's an erector, so a spinal extensor, and singularly, if we contract one side or the other, it's a lateral flexor. So this muscle group is particularly active if we're doing single-legged type exercises, because we have to stabilize that pelvis. If I'm standing on my right side erector spinae has to isometrically control so that my hip doesn't drop, so that I don't collapse on that non-support side. And the erector is going to get its innervation directly from the spinal nerve roots. Okay, rectus abdominis. I would show you mine, but it's not appropriate. So I'll keep my shirt on. You're welcome. These are the rectus abdominis muscle, even though we're used to seeing that six-pack, these are just tendinous insertions within a common muscle, so they're not individual muscles. It's going to originate on the pubic crest, and then it's going to insert on ribs 5, 6, and 7, and then the xiphoid process centrally. So you've probably done core or ab exercises. You know it's going to be a trunk flexor, and then single-sided it's going to be a lateral flexor, and it gets its innervation from the intercostal nerves. Okay, now the obliques. Okay, lots of times we treat them like, okay, they're the same muscle, but they're not. Okay, the internal and the external obliques function as a pair. Typically, the external on one side will function with the internal on the other, and vice versa. So the external oblique, you can kind of think about its orientation as, if I'm putting my hands in my pockets, that kind of direction, inferior medial, that kind of shows you the direction that external oblique goes, and you can see how it kind of weaves together with the serratus anterior that we talked about in the shoulder. Okay, so this is going to originate on the borders of the lower 8 ribs. It's going to insert into the rectus abdominis primarily, but also into the pubic crest inferiorly, and then the fascia of the ab. This is going to assist in flexion if we fire both sides concurrently. One side or the other is going to contribute to lateral flexion and rotation, and this is an important derotator in the core. So if I'm doing something where I'm trying to take a punch, okay, if I punch somebody, then Newton's law tells me there's an equal and opposite reaction. So that force wants to rotate me back. So the muscles of my core that function in the transverse plane can help stabilize that and prevent that action. Okay, so the external oblique is innervated via the intercostal nerve. Now the internal oblique is going to be deep to that, as the name might give you a hint. External is external, internal is deep to that. So in this picture, we see the external has been dissected away, and the internal kind of runs opposite. So we said hands in pocket for external. I don't know what this is, but from inferior superior medial for the internal oblique. So kind of think hands on hips for internal oblique maybe. So this is going to originate posteriorly at the inguinal ligament and then the anterior 2/3 of the ilium. This also is going to insert into the costal cartilage and the lower 2 ribs. Again, this is going to assist with flexion and lateral flexion. So if you think about the true orientation of these fibers, and then if you think about the external oblique here, you can see how these muscles could work in a pair. Okay, so external on my right is going to function oftentimes with internal on my left. So if I'm throwing a baseball and I'm following through and I'm rotating and flexing all at the same time, that external oblique on the right and internal oblique on the left are helping that action to occur. Okay, the same thing's true with the opposite side. So lots of times we will train these muscles collectively. So you've probably seen people, they'll do a crunch with a side twist, and they say that's an oblique crunch. Maybe EMS. The EMG data would tell us that we don't get a tremendous amount of additional activation from that side bend. Instead, things like a med ball slam, where I'm going from high on one side to low on the opposite side, or a lawnmower pull, where I'm using a dumbbell or a kettlebell and I'm pulling from low on one side to high on the other. That's going to train those obliques in the way they actually function. So those exercises are going to be much better at training the core the way it actually moves. We don't do a lot of resisted lateral flexion in isolation in sports. You show me an example of an athlete doing that, I can't think of one, but I can see plenty of examples of an athlete who follows through with a throw, or they're going to pull and rip and rotate away. That happens far more frequently. Okay, the QL. This is an important posterior muscle. So it's going to originate on the iliac crest, posterior hip, and it's going to insert into the 12th rib as well as the L1 lumbar vertebrae and the entire lumbar spine. So coupled together, left and right QL activation is going to lead to extension, one side or the other is going to lead to lateral flexion, side bending, basically. So if I'm doing let's say a hex bar deadlift, okay, or even better, kettlebell or a dumbbell, and I'm holding it in kind of a farmer's carry. If I'm doing that kind of side bend, I'm using QL on the stretched side. So if I side bend to the right, I'm contracting that right QL, and I'm stretching the left QL, and now I'm going to pull back to neutral, and I'll use the left to trigger that lateral flexion. Okay, coupled together on something like a glute ham raise or a donkey kick, something like that, I'm going to use the QL to extend the spine. It's going to get its innervation from T12 and the L1 spinal nerve. Okay, TA. This is one of the most important core stabilizers that we have, and it's deep, and it really doesn't get the attention it probably deserves in fitness circles. People are more interested in training the obliques. They're more interested in training the abs because those are visible, especially in bodybuilding circles. But the transverse abdominis is deep. Okay, we talked about the skeletal structure and how the ribs articulate with the thoracic vertebrae and give us structure, and the lumbar spine is kind of left hanging. There's no skeletal structure supporting it. Well, the transverse abdominis provides that. Okay, sometimes this is referred to as the muscular corset. Okay, so if we contract transverse abdominis, it can stabilize everything in that lumbar spine region. So it's going to originate on the inguinal ligament and the inner surface of the lower 6 ribs. It's going to insert medially into inferiorly at the pubic crest, and then more superiorly at the abdominal aponeurosis. This is going to assist with forced expiration, and it's not a huge prime mover in terms of flexion, extension, rotation. It's more of an isometric or a stabilizer, so it provides added support to that lumbar spine. So if I've got a sprain in my back, say I've got an injured disc and I've got injured ligaments, if the ligaments are stretched, then that static support is gone. So unfortunately, we know that chronic back pain leads our body to kind of shut these muscles down. They get inhibited. Our body wants us to stop doing what we did that triggered that pain to begin with. So say you've got a sore back for a week or so, and you go into squat, you're now, not only do you have that initial injury, you also have some inhibition in the muscles that are providing secondary support. So it's really important to get that muscle turned back on. So we can do some specific activation exercises to kind of turn its activity back up. Okay, so it's going to get its innervation from the intercostal nerves. All right, so tune in next time. We will take a look more specifically at the muscles of the head and neck. But until then, this is Dr. Brooks signing off.